Hello, everyone. This is episode 2 of Interstitial Lung Diseases, which is a webinar international with Professor Stephen Nathan. Fibrotic HP is the most common ILD which we see in their practice, and when we see, it is far advanced. And the major confusion is that these fibrotic lungs are due to HP or CTD or sarcoidosis. And it becomes very difficult in our daily life because most of them cannot be subjected to biopsies. Neither the history is so forthcoming for either CTD or HP or sarcoid, and HP panels do not contribute to make a diagnosis, and CTD profile, which may be negative, even autoimmune symptoms may be negative, and still it can be one of those occult CTDs which may manifest later on. In these scenarios, the radiology helps a lot. Triple density sign in hypersensitivity pneumonitis gives high level of confidence, but seen only in 50% of fibrotic HPs. NSIP, which is the highlight of CTD ILDs, is also seen in 20% of hypersensitivity pneumonitis. And sarcoid is the greatest mimicker, can mimic and present like anything. So how do we navigate this? To help us in making the decision-making about the diagnosis of fibrotic HP, we will be aided by Professor Steve Nathan, Dr. Khushbu Pelania, who's going to be the radiologist, and Dr. Charul Dabral, who's the our pathologist. It is case-based, and case will be presented by Dr. Kanish Kumar.
So this is the case 1, 54 years, male, former smoker with pack year of 4, retired desk job, and presented to us with the complaints of shortness of breath which progressed from grade 2 to grade 3 MMRC for last 3 years. Patient had the complaint of dry cough for 3 years, increased in intensity and frequency for last over 1 month. There was also a history of dryness of mouth from the patient. This was the X-ray which we obtained from the patient. We talk about the comorbidities. There was no comorbidities. There was no history of pulmonary tuberculosis in the patient, no history of ILD in the family, but there was a history of exposure to pigeons, which was present for last 14 years, and still it is ongoing with the patient. So in this slide, you can see the X-ray. Vishnu ma'am, you want to comment on that?
Go ahead, leave the X-ray. Go ahead, go to the CT scan. Yeah.
Okay, general examination was normal, blood pressure normal, pulse 88 per minute, respiratory rate was 21, saturation was 97% room air. This was the lab investigations which we obtained. TLC was 12,500, CRP was slightly high, which was 15, not very high. LFT is normal, KFT is normal, vitamin D312. ECO was suggestive of 55% ejection fraction, no pulmonary artery hypertension. When we did the autoimmune profile, the ANA was 1:320, cytoplasmic speckled. ENA, JO1 was positive. In myositis profile, JO1 was positive. HP panel was suggestive of pigeon serum proteins positive, and the number was 159, which was significant. RA was negative, anti-CCP negative, and only serum ACE was higher, which was 75. Now, this was the pulmonary lung function test. FEV1 by FVC was 80.86, FVC 56%, FEV1 56, suggestive of restrictive pattern with the DLCO of 47%. On 6-minute walk test, it was normal. We move on to the CT scan. So I'll show you the inspiratory one.
So Kanishk, on the basis of a clinical findings of a 54 years male, what is your differential diagnosis on the interstitial lung disease? What are the conditions you have in your mind?
I think first, there is a significant exposure history which is present in this patient, which is to the pigeons. So definitely the first diagnosis which comes to my mind before seeing the radiology or the CT scans is the hypersensitivity pneumonitis. What do you think, sir?
So we have some autoimmune profile positive, some subtle symptoms of CTD. We will keep as CTD ILD as a second possibility in our mind. And I think serum ACE has nothing to do with it. But in India, we see sarcoid ILD. So we will be asking our, I think you can choose, yeah, inspiratory, expiratory, you can run together. And we will keep sarcoid also, but IPF will not be on our cards as far as the history, age, and other smoking history is just 4 pack years. So I think we have a radiology coming up here, so we can see the radiology. And first, we will ask Dr. Stephen his comments, and then Dr. Khushbu that what she feels like it.
Yeah, I was impressed by the history and the pigeon exposure. I think that raises the possibility very high that this is chronic HP. The CT, I think, is certainly compatible. It looks like there's more upper lobe disease going through. There might be some micronodular uh, um, uh, evidence of micronodules in the upper lobe, centrilobular nodules. The bases are relatively spared. I don't see subpleural reticulation. I didn't see honeycombing. The esophagus is pretty wide open, so could he be aspirating as well? Although I doubt that's the explanation. His pulmonary artery segment looks pretty good. No pulmonary hypertension, seemingly. And then the CTD panel is very interesting. I think that the myositis was positive, the JO1, and the ANA, you can have borderline elevated ANAs in many of these patients and in the normal population, but 320 is getting up there. So I think CT, my number one differential would be chronic HP. I agree with that, but I wouldn't rule out a CTD. And I think what this brings to light is a multi-hit hypothesis that it could be a little bit of this and a little bit of that that sets the patient up for progressive fibrosis. These patients are never clean. We like to put them in one particular bucket, but it could be that there's a little bit of an underlying CTD. There could be that there's, looks like there is some air trapping when we look over here. I think on the expiratory films that seeing on the sagittal side that there was some areas of hyperlucency. So these are also very helpful. I think when I look at the CT though, I'm leaning much more towards chronic HP, but we'll keep CTD in the background as well.
Dr. Khushbu, coming to you, obviously these two are already kept into differential. I would ask you, is a sarcoid a possibility? Because we see a lot of sarcoid also.
Yes, sir. So sarcoid is again a possibility. If I am asked to put these in a chronological order, I would say chronic HP as it's compatible with chronic HP. Second on my cards will be sarcoidosis and then CTD ILD. So it's definitely a kind of a micronodular pattern as well, with the fissures also appearing relatively more nodular than we can explain by simple fibrosis.
That's a good point. When you say the fissures are more nodular, is that what brings up sarcoid a little bit higher in the differential?
I think we have lost her internet connection. She'll be back with us.
Okay.
But in the meantime, I think, yes, these are the three main differentials for us when we look at fibrotic ILDs in India. And many a times there is one or the other finding which is trying to push into one diagnosis. I would ask you one thing. The patient has given history of 14 years of ongoing exposure to pigeons. Is it the CT looks like that the disease is of that, like it's been going on for years, or it is like it's not that significant that 14 years of exposure, like I do not know how to place that very importantly.
I think that's always hard, and then you look at the restrictive physiology, the FVC around 54%. I think this probably has been going on for years. Maybe the patient wasn't that active that he didn't notice his symptoms and presented relatively late. But yeah, I would, the 14 years, it's very hard to pinpoint exactly when this all started. But I would suspect that this has been going on for a good number of years at this point.
So, Dr. Khushbu, you were talking about the CT findings. Kanish, you can play that inspiratory, expiratory scans.
Sir, in this case, we could very well see on the inspiratory scans that there is a diffuse lung disease, which is showing a diffuse axial distribution and upper zone predominance. There is a combination of reticulations and ground glass. So all of these features are compatible with an HP diagnosis, wherein we are looking at reticulations, ground glass, upper zone predilection. Air trapping is not as much as we are expecting, but there are significant areas of air trapping as well, more towards the basal zones where we are not seeing as much fibrosis happening. So that's how, and it's definitely an alternate diagnosis pattern which puts chronic HP sarcoidosis because of the fissural nodularity. And yes, of course, we cannot rule out this being a combination of some of a CTD ILD as well.
Especially when the esophagus is very frankly dilated. It's like trying to tell us that there is something there in the esophagus. I think these were the three differentials. Kanish, can you bring that pre-biopsy MDD? What was our this thing? Sarcoid, CHP, and CTD. So all three are there. But
Yes.
I think at that point of time, maybe one of the radiologists was more inclined towards the sarcoidosis in the view of the fissures being very nodular in this patient, although the lymph nodes were very small, I think mostly insignificant. But anyways, since all three are the competing diagnoses, it is very difficult to reach the high level of confidence. So Steve, in those situations, like in this case, you tell me that in your scenario, what would you recommend in such cases? Where in this case, what is your recommendation?
You know, the question is, for us, do we need more tissue? And I agree with this differential, but we always got to contextualize it in terms of the severity of the disease. There's a good amount of fibrosis. Maybe the CT underrepresents how much fibrotic changes there are once again, and the patient has marginal lung function. I'm not sure this is someone I want to chase tissue on. And then the question I always ask myself is this going to make a difference in management? Even if I had more tissue, is it going to alter what I'm going to do? And arguably, you can say, yeah, well, sarcoid, you know, we might lean more towards methotrexate and steroids. But is that really a reason to chase after this? Would a bronch with a BAL be helpful at all? If there's a lymphocytosis greater than 60%, that helps with chronic HP. I'm not convinced that a bronch with a BAL is going to be that helpful or alter what I'm going to do. I think this is someone I would put on therapy and see how they respond, because whatever it is, be it sarcoid, chronic HP, CTD, they warrant therapy. So I would probably lean to put them on a course of prednisone, and I would probably at the same time put them on an immunosuppressive agent like mycophenolate, and just to see how much reversal we can get. Be this a chronic HP, be this a CTD or sarcoid, there's very possibly an inflammatory component to this that is reversible. So that's what I would do. And I would give it, you know, a couple of months to see how much improvement hopefully we can get from immunosuppressive therapy. And then I'm impressed by the amount of fibrotic changes, and whether the fibrosis from sarcoid, chronic HP, or CTD, I would look to layer on an antifibrotic therapy, and the only one we have for progressive pulmonary fibrosis being nintedanib. So that's what I would look to do. I wouldn't do the mycophenolate and nintedanib together. They both have GI side effects, and it's going to be hard to figure out which one's doing what. So being that the steroids and mycophenolate are the agents that are most likely to affect reversal and improvement, I would do those first, get the patient on a stable dose, and then to prevent further fibrosis, I would look to layer on an antifibrotic after that.
I think that's a wonderful insight in the future of this case. Let's see what we did. Kanish, can we carry on? Go ahead. I think the slides, biopsies, because we did biopsy.
Oh, you did?
Yeah,
You see, the first case, I was more aggressive, and now this case, you're more aggressive.
Bronchoscopy guided BAL and EBB with cryo-TBLB. And now we have the BAL, which was suggestive of 40% of lymphocytes. And I request Charul ma'am
Yeah.
for the
I think Dr. Charul, Can we have the opinion of Steve on the slides of the biopsy? Because this is a TBLC, so I think let's have Steve give some opinion and then you direct us through the slides. That will be a nice way of doing it. Ganesh,
I can fake being a pathologist for 5 seconds, but show me the slides and I'll take a look. So looks like a lot of fibrotic changes here, kind of diffuse. Trying to see if under this viewpoint, if I can see any granulomas or anything. All I can say is diffuse fibrotic changes. I'm not seeing a particular airway to say that it's airway centric, although that looks like, I don't know if that's a big airway in the middle, but I would just say diffuse fibrotic changes. I don't see much in the way of inflammation.
yeah, so I think Kanishk, you can quickly go through all the slides first so that let him have the view of all the tissue which we had.
I would call this peribronchial metaplasia. Okay.
So I think Dr.
Yeah.
Charul would like to comment on that. Dr. Charul, what are we looking at this? These are the TBLC tissues.
So you can see there is peribronchial metaplasia, but there is a predominant small airway distribution of the disease. The disease is around the bronchioles and the alveolar ducts. And we can also see that there is some cellular interstitial inflammation, which is centered around these alveolar walls and the bronchioles, which we term as cellular bronchiolitis. And there is extensive smooth muscle hyperplasia also. So there could be some bronchiolitis obliterans as well. And there's a lot of pigment. And in the periphery, there is some NSIP pattern, which I can appreciate in this biopsy.
Go ahead, Ganesh.
In this application. So in this biopsy, again, you are seeing peribronchial metaplasia with the cellular bronchiolitis and disease centered around the small airways with extensive smooth muscle hyperplasia. And at the periphery, there is some NSIP pattern. So this is a higher magnification just to show a lot of smooth muscle hyperplasia. So this could be bronchiolitis obliterans causing smooth muscle hyperplasia with cellular bronchiolitis and a lot of pigment. And here, obviously, you can see some ill-formed granulomas, which are centered around the bronchioles and a lot of pigment with smooth muscle hyperplasia. So we are getting like a lot of major features in this case. We have like airway-centered disease with cellular bronchiolitis, and we have inflammation, which is mainly lymphocytic, and we have ill-formed non-caseating granulomas, which are centered around the airways with a lot of pigment. And this is the area higher magnification to show you the NSIP pattern in this biopsy, which obviously can occur in HP. And there is a lot of pigment with smooth muscle hyperplasia. This is another area which is showing organizing pneumonia-like pattern, OP pattern, with the alveolar air spaces filled with fibrinopurulent exudate. And so there is a plugging of the air spaces. Same higher magnification of the same. So there's areas of organizing pneumonia as well. Yeah, there's some foamy macrophages, a lot of pigment is here. So this is again the area of organizing pneumonia. So yeah, I would typical of HP, non-fibrotic HP, because I could not appreciate fibrosis in these biopsies.
Okay, so compatible or typical are the two words which are used in the guidelines which Steve has shown. But anyways, you are between whatever the tissue we could give you. So whatever you have shown us, it looks that we are into the alternate diagnosis. Your comment, Steve?
No, I think that from what I could see there, it certainly looks compatible with chronic hypersensitivity pneumonitis. You know, I think that we saw a poorly formed granuloma, not well formed like you would typically expect in sarcoidosis. There is some inflammation, a cellular component to this. So I go back to my point. It's nice to have the biopsies and see everything. It kind of clinches the diagnosis of chronic hypersensitivity, but I think the management stays the same.
Right, correct. And I think you were very good, accurate in predicting that won't be much fibrosis. We didn't see much fibrosis here. The patient requires steroids and immunosuppressives.
So now let's discuss about the algorithm for the diagnosis of hypersensitivity pneumonitis. This was taken from the article that was published in Chest in 2022. So according to this, we have to take the history from the patient, the history about the antigen exposure. So now in the clinical context, we have taken the history about the antigen exposure. If you have identified, or if the exposure is indeterminate or it is unidentified. In all scenarios, we should go for a chest imaging. So we'll do the HRCT scan, discuss with the radiologist, and if the radiologist has an opinion that is suggestive of typical of hypersensitivity pneumonitis, in that scenario, you will not be doing any further bronchoscopy, which is bronchoalveolar lavage, and then you label according to the multidisciplinary discussion as the diagnosis of hypersensitivity pneumonitis. Suppose after the HRCT scan, you get the possibility of compatible or indeterminate of hypersensitivity pneumonitis, or maybe typical or compatible or indeterminate in the all the scenarios, then you have to think about doing the bronchoscopy, and we go for bronchoalveolar lavage. In that, we see lymphocytosis. So if the lymphocytosis is present, then it is provisional and high confidence. So in this scenario also, you don't have to go for any further pathology to get the confirmation of the diagnosis if the confidence level in the multidisciplinary discussion is high. In second scenario also, when you do our BAL for lymphocytosis and your provisional diagnosis is HP with high level of confidence, then also further we will not be moving ahead. Similarly, in the unidentified antigen exposure scenario as well. Now, with MDD diagnosis of provisional or low confidence for hypersensitivity pneumonitis, in this scenario, with again we get the provisional low confidence, or when the HP is unlikely as well with the indeterminate exposure, and with unidentified exposure, we will go for lung histology for the confidence. So whenever in the MDD diagnosis, MDD discussions, the confidence level is low for HP, in that scenarios, we'll go for biopsy or transbronchial lung cryobiopsies to get the histopathology of the lungs. Now, on the pathology, we'll be discussing again. I will have the meeting again with the pathologist on the board as well. And if it is typical for hypersensitivity pneumonitis, then you label the diagnosis as MDD diagnosis as hypersensitivity pneumonitis. If it is compatible with HP, then it can be HP, or you may have a provisional HP as the diagnosis if it is indeterminate for HP as well. Or if you get an alternate diagnosis, then of course the patient is not having HP. Talking about the confidence level or the diagnostic confidence, HP, if the confidence level is more than 90%, if it is high confidence, then 70 to 89%, with low confidence it is around 51 to 69%, and unlikely it is less than 50%. So this is the algorithm, and we'll be focusing on the patient. When the patient comes to you, you'll be going through all these stages to label the patient as hypersensitivity pneumonitis according to the multidisciplinary discussions.